Hopefully this video will be better than the last one. The connection here is goofed up, so I had to kind of modify things a little bit. But no, you won't. I'm a fail as well. Shift 63, right? 62. Oh, that's right, we're 63. Okay, yep, you're right, 62. Thank you. Grammar counts, okay. They don't. That's okay, no one else probably has either. All right, I'll allow that last person to jump in. We want to get started so that way you guys can get to lunch on time, right? All right, which of the following situations would encourage oxygen to dissociate from hemoglobin? The case here, low temperature, low CO2 concentrations, high hydrogen ion concentrations, or high O2 concentrations. So again, this is encouraging oxygen dissociation from hemoglobin. Yeah, no, we just covered this, or we'll actually cover it in the last section, so she have some recollection. All right, yes. So remember, when you're in the tissues, usually the temperature is going to be what compared to the lungs? Should be higher, right? Because again, we're producing ATP. Think about like exercising muscles. Think about that heat production there. Temperature goes up. Temperature is going to do what to that dissociation? High temperature should cause offloading. I should call it the offloading of oxygen to the tissue. That makes sense because then when I get up to the lungs, where it's going to be a little bit cooler, this is going to do what? It's going to favor that loading, right? It's going to cause that shift over the curve over to the left. You're going to be picking up more oxygen, right? So again, by design, we're meant to be very efficient about picking up oxygen where we're needed to, and then dropping off where it's needed, essentially, right? Low CO2 concentrations, that would not be the case necessarily, because if I had low CO2 concentrations, what do you think that would do to the pH of the blood? It would make it more alkalotic, right? Because again, low CO2 means we're going to have fewer hydrogen ions there, which again, in this case here, the pH is high if I have high hydrogen ion concentration. Remember, the pH should be low in this case, you're acidotic. So low pH does favor that unloading, because again, if I have acidotic tissues, that probably means I need more oxygen there, because I need to be able to produce ATP from aerobic respiration and not produce, rely on things like lactic acid production and all that, right? High O2 concentrations would not be the case either necessarily. However, you're going to see that, as you have lower and lower hemoglobin concentration, that saturation goes down. You do see some favoring of offloading in those cases there, but high O2 concentration would not do that necessarily. Okay, make sense? All right. Delaying the repolarization phase of the myocardial action potential would increase which interval? PR, QT, QRS, what do we think? So you got to think back, what are your different waves referring to as far as what's going on in the cardiac cycle? All right, QT interval is correct. So remember your basic EKG. The P wave is what? P wave is what? P wave is atrial depolarization. If you guys everyone can hear me, right? Or the fan's not. I can't hear you as well, but let's see if you guys can hear me. But QRS is what? the ventricular depolarization, and then the T wave repolarization, right? So the repolarization is the T wave there, right? So again, if I was to have, say, for instance, what would increase, say, the PR interval? What do you think? Because again, that's that time from the atrial depolarization to the ventricular depolarization. What do you think could delay that? Hmm? Well, not necessarily ion flow necessarily, but what if, like, for instance, I had some kind of slowing of that conduction between the atria to the ventricles? Because remember, it needs to go through the basically, remember, there's a fibrous tissue that separates the atria from the ventricles. It needs to go through that bundle there in order to make sure that we have good, appropriate conduction through the heart, so it beats, and not all at one time, but it beats in the appropriate cycle there. So if you had something like delaying that conduction, that would be increasing the PR interval. So the time from the atrial depolarization to the actual ventricular depolarization would be increased, right? Now, say, for instance, you have something, everyone ever heard of like Wolff-Parkinson-White? So that's actually something where you have a little bit of connective tissue that actually conducts from the atria to the ventricles that's outside of that normal bundle there from the SA node down to the bundle branches. And so what you end up finding, or I'm sorry, AV node to the bundle branches, what you find there is that they actually would actually cause a decrease in the PR interval, because now you have this extra piece of tissue that's conducting a little bit faster, and that can actually decrease the time from the atrial to the ventricular depolarization. Right? So that's one case where we may see that being decreased. The QRS interval is just going to be what? So that's ventricular depolarization. So basically, the thing that would modify that would be if I was actually slowing down the speed of depolarization. In that case, that's actually by blocking the sodium channels. Because remember, when you have the depolarization at phase 0, that's caused by what? Sodium influx, right? So if I slowed that down, I took a longer period of time for the actual potential to occur, that would actually widen out the QRS, right? So when I was talking about the TCA overdose, that amitriptyline overdose, that's one of the things you see is a widening of the QRS, because it actually blocks the sodium channels and slows that whole process down, okay? So then the other thing would be the QT interval, right? And so this is the time from the ventricular depolarization all the way to when you have the repolarization, okay? So what do you think could affect that? This is where if I was, because again, what causes the repolarization to occur? Potassium. Was just potassium inside, in or out? Efflux, right? Good. So remember, the repolarization is primarily driven by potassium efflux. So if I block those channels, say for instance with a medication, guess what? I can then slow down that repolarization phase, and I will have a lengthening of the QT interval there, right? And that's no good. There's actually one of the things you want to be careful of is drugs that prolong the QT, because you mix a bunch of them together, you can end up causing an arrhythmia called torsades, right? You don't want that to occur. Yes, sir.
With calcium making that plateau of the of that, I guess, repolarization phase, could that calcium level also affect that?
So the plateau phase, that's not really the repolarization. Really, the calcium is kind of keeping it at that kind of depolarized state, right? Because the calcium's flowing in the positive ion, so you're going to see that. That's why that plateau occurs, and then you have the repolarization happen there. Yes, by modifying the amount of calcium you have, you may be you can modify some of those intervals as well. Again, I'm not going to get into specifically there, but yes, having too low a calcium or too high calcium can lead to arrhythmias additionally. But potassium efflux is the big thing. That's why you ever hear like QTC prolongation. It's a big deal as far as like drug interactions go, and some people actually have congenital like genetic defects where they actually will have those potassium channels that are defective, and they have a prolonged QT anyway, and they actually are more prone to sudden arrhythmias and death potentially. Yep. So again, that's why whenever you're working someone up for like unexpected syncopal episode, you check an EKG and you want to see what their QT interval looks like, because it could have been a case of that. Okay, make sense? All right. When examining lead V2 on an EKG, what is the negative lead considered to be? Left leg, center of the heart, the right arm, or the left arm? Absolutely. The winner gets a free answer. Don't forget. It's always the rule of my cahoots. The winner always gets a free answer at the end. All right. Interesting. Interesting. Right. Okay. So remember, we have our unipolar leads and we have bipolar leads. Okay. So which ones are our bipolar leads?
AVR.
No. That's going to be 1, 2, and 3, right? Remember, because those are going to be cases where we're looking, in the case of, say, like lead 1, where does lead 1 start? We're looking from the left arm to the negative is going to be on the right arm in that case, right? Versus, say, like lead 2 is what? Like the left leg up to the right arm, right? That's lead 2, right? So again, remember, you're always looking, the positive electrode is always going to be the camera. That's how you're looking back towards the negative in those cases, right? Those are the bipolar limb leads, right? In the case where you're dealing with like AVR, AVL, AVF, and then your 6 ventricular leads, you're going to find that those are going to be unipolar. Those are going to be looking at the negative, which is located where? In the heart, right? So again, your negative is always considered to be in the heart when you're looking at these unipolar leads. Okay, got it? So if I said AVR, what would the answer still be in this case? Still be the center of the heart. If I said lead 2, what would be the answer? Be the right arm. Okay. If I said lead 3, be the left arm in that case. Remember, because lead 3 goes from the left leg up to the left arm. Review that stuff. That might be on the test, right? Okay. Does my EKG friend agree? Does that make sense? Yep. Thank you. I would like to check with the experts to make sure I'm saying stuff correctly. Anyway, as it turns out, I am quite fallible. Just make sure I'm still recording. Yes, okay, good. All right, exposure to which protein kicks off the extrinsic clotting cascade? Perfect. Tissue factor is correct in that case, right? What's happening with the intrinsic cascade? How it kicks that off? It's collagen, right? Because collagen is going to end up binding with that von Willebrand's factor on the platelets. And it gets involved with factor 8, and that's kicking off the intrinsic cascade. Tissue factor, though, is going to be for the extrinsic, right? And then thrombin, when does that get affected? Yeah, it's the end of the common pathway, because then thrombin does what? Does thrombin itself form the clot? It turns fibrinogen over into fibrin. Perfect, right? So that's the final step there, right? Because again, you have the platelet plug that's already there, and then you're going to have thrombin. It's going to convert the fibrinogen over to fibrin, and that's what causes that kind of that sticky web there. It's going to hold everything in place. That's when you actually have your clot itself. Okay. And so kind of review that. That might be on the test as well. Which of the following waves represents atrial depolarization? Everyone should get this one because we already talked about it. Perfect. Yes, the P wave is the atrial depolarization. Where's the atrial repolarization? Can't be seen. The QRS, because again, think about like the muscles there are so much bigger in the ventricles, it covers that up. Just that wave of depolarization is so much stronger than the atrial repolarization there. Perfect. Which of the following would have a natural antihypertensive effect? Which hormone? The antidiuretic hormone, aldosterone, atrial natriuretic peptide, or norepinephrine? What do we think would have a natural antihypertensive sort of effect? All right. Okay, so let's walk through all these different hormones, see what they're doing, right? So specifically antidiuretic hormone, what does that do for us? Holds on to fluid, perfect. So it's going to be reabsorbing water from the kidneys. Good. What else does it do? Increases thirst, absolutely. So I'm going to be taking in more fluid, which should also cause my blood pressure to potentially go up, right? What else? It's also causing vasoconstriction, right? So this would only cause blood pressure to go up with antidiuretic hormone, right? It would not cause it to go down in these cases. Aldosterone, what is that going to do? Yeah, there's going to be salt and water retention, right? So again, that would also not have an hypertensive sort of effect here. What stimulates aldosterone release? ADH may have some influence, but the primary thing I'm looking at is going to be what? Because remember, there's a something aldosterone system. Renin, angiotensin, aldosterone system, right? So renin and angiotensin 2 are going to be the big thing that's going to be driving production of aldosterone, okay? So again, think angiotensin 2. Angiotensin 2 would do what to blood pressure? It's going to increase it, right? It's going to be pretty potent vasoconstrictor, so that would not be correct. Norepinephrine would do what for us? It would increase it by what action? Causing vasoconstriction on what receptors? Beta 1 on the heart would do what? Well, beta 1 on the heart would do what in this case? It would increase heart rate, it would increase contractility, right? So that would be one thing that would be potentially increasing blood pressure, because again, if I have more coming out of the heart, that pressure is going to build up. What's the other thing it's going to do as far as vasoconstriction goes? Remember, alpha 1 is constrictive, right? So alpha 1 will cause constriction of the vessels that will cause blood pressure to go up. If you have beta 2 activation, that's going to do what? That actually causes some vasodilation. So you might see some mild vasodilation, say to the muscles and things like that, right? Think about your sympathetic nervous system being activated there. But alpha 1 is always going to be constrictive. Beta 2 tends to be more of a relaxing sort of effect, right? Think about the lungs. Think about beta 2 receptors causing relaxation of the bronchial smooth muscle. That's why we use albuterol, a beta 2 agonist, for asthma, right? And then atrial natriuretic peptide, so that would be the correct answer, is causing a antihypertensive sort of effect. What is this doing? What activates release of this? So stretch of the atria, right? Because it's right in the name, atrial natriuretic peptide. So again, the stretch of the atria. And again, what could cause that stretch?
High blood pressure.
Well, so what, as a result of increased blood pressure, increased preload or afterload? Preload in this case, right? Because I have more volume coming back, right? So my end diastolic should be going up as well, but you're going to find that as more volume comes back, it's going to stretch out the atria. That will release atrial natriuretic peptide. So we know it comes from the atria, and then what's it going to do? Yeah, you're going to lose sodium and water, right? So again, because it's natriuretic, think salt, pee out salt, right? You're going to see that can help to lower blood pressure, okay? So keep those in mind. Now imagine if, say for instance, I had a patient who was having a massive hemorrhage. They lost a whole lot of blood, and they got into a car accident. They're being life flighted to our trauma center, losing a whole bunch of blood. Which one of these do you think could be stimulated? All the other three, basically, yeah. So think about that, right? So think about you lose a lot of blood volume. I need to get that pressure back up to make sure I'm perfusing the heart and the brain. So I'm going to have things like aldosterone being increased, right? Because the kidneys are going to detect there's not enough pressure there, right? So that's going to increase release of renin. That's going to then stimulate production of angiotensin 2. It's going to increase aldosterone release. Antidiuretic hormone is going to be picking that up as well. Norepinephrine due to the sympathetic activation, right? So think about these changes that occur based on the clinical scenario, okay? Because you might have questions like that on the test. Okay. Which complement protein is responsible for the opsonization of pathogens? Like putting a little bit of sriracha on the bacteria, making them a little more tasty, a little spicy. Actually, C3, good. What's C9 and 5 doing?
Destroying.
Yeah, so 5 through 9 are going to help with that actual punching a hole in that bacteria, the pathogen, causing that lysis to occur there. C1's doing what? Part of the recognition proteins there, but C3 is the main one that's going to be doing the opsonization, right? Making it a target for other phagocytic cells to come in and actually eat up the pathogen, right? Good. All right, increased activity of nitric oxide would have what effect on the cardiovascular system? It would cause vasodilation, cause vasoconstriction, would it increase afterload, increase preload? What would I see happen due to nitric oxide pathway being upregulated? And you know the difference between nitric oxide and nitrous oxide?
They're spelled different.
Yes, they are spelled differently, thank you. What is nitrous oxide used for? They use it maybe in the Fast and the Furious, maybe to help the cars go a little faster. It's laughing gas. So if you hear nitrous oxide, it's laughing gas, right? So you can use that at the dentist or light procedural sedation. We'll talk about that in Pharm 2 later on. Anyway, so remember nitric oxide typically does what to the endothelial smooth muscle? Cause relaxation, right? So again, by increasing nitric oxide causes smooth muscle relaxation. Think back to when we talk about nitroglycerin and affecting the coronary blood vessels, right? So again, when you have chest pain, call it angina, right? Why do we have angina? We don't have enough oxygen being delivered to the myocardial tissue, right? So I wanted to vasodilate to get more blood going there. So I need nitric oxide to be upregulated, right? That's why I give nitroglycerin, because that will then stimulate that pathway, right? That's going to open up those vessels, it's vasodilatory, and cause a better perfusion of the heart, right? So that's why it relieves angina. So it would not vasoconstrict. And then in this case, if you have a relaxation of the vessels, what is that going to do to the afterload? Should decrease it, right? Because again, afterload is just that pressure that the heart's having to pump again, so that should be decreased, right? So you should see an antihypertensive sort of effect if you were to give someone, say, nitroglycerin, say via IV, and that's actually one of the big things you're going to see with those patients if you're giving it to them. You'll see their blood pressure come down a little bit, which is probably good because those patients probably have long-standing hypertension anyway. And then how about the preload? That actually would tend to go down in these cases, as you will see that when the vessels are more dilated, they can hold more blood. So that's going to be meaning you have a little bit less necessarily going back to the heart. So again, the veins, as you said, those are capacitance vessels. They can then hold on to a little bit more blood, and so you have maybe less of it coming back with each successive beat of the heart. Make sense? Okay. All right. Which of the following differentiates pacemaker cells from other myocytes? They have no sodium potassium ATPase pump. They have slow inward sodium leak. They have slow inward calcium leak, or they lack a refractory period. Interesting, almost an even split across the class. Okay, so remember, all the myocytes are going to have a sodium potassium pump, right? So a sodium potassium ATPase pump, right? Because what do?
Get it back to the resting membrane.
They help us to maintain the resting membrane potential, right? So they're going to be sending potassium in or out of the cell. Potassium in against the concentration gradient, sodium out against the concentration gradient, right? Those are going to keep everything regulated, right? It's going to keep the resting membrane potential right where it should be, okay? Now, they don't have a slow inward calcium leak, but however, where does calcium become important with those cells? The depolarization in these cases, right? So again, with most of the other myocytes, you're going to find that inward flux of sodium causes depolarization. For these cells, these slow response cells, you're going to find that inward flux of calcium causes the depolarization, right? That's why I can give something like a calcium channel blocker, and that actually slows down the heart rate because it will block that calcium coming into the cell, okay? Slows down that depolarization. And every cell is going to have a refractory period. That you have to have a refractory period because guess what? Otherwise, you'd have action potentials just kind of being propagated all over the place. And again, nothing would be stopping those cells from having another action potential too soon, and you just basically get this quivering mess of myocardial tissue, right? You don't want that. Typically, you want the heart to be beating in a nice concerted sort of effort there. So, in these cases, though, they do have an inward leaky sodium channel, which allows for the resting membrane potential to gradually increase. And then once it gets to that threshold, guess what? Calcium channels open up, then you have a depolarization, right? Okay. Which of the following connections is considered lead 3? I already gave this one away, so let's see. Would it be left arm to right arm, left leg to right arm, center of the heart to the right arm, or left leg to the left arm? So one last person, just waiting to the last second, get their answer in. All right, so in this case, it would be the left leg to the left arm, right? In this case, is this a unipolar or bipolar lead? It's bipolar, right? Because all the unipolars are going to end up in the heart, right? Because again, we have to calculate kind of where the negative is, so to speak. The machine does that for us, but again, there's no actual negative lead there. We're just kind of mathematically putting it in the center of the heart, essentially, right? In this case, though, for lead 1 would be which one? Left to right arm, right? Or left to right arm, I should say. I don't know my left and right, apparently. Lead 2 would be left leg to right arm. Good. And in this case, what would be center of the heart to the right arm? AVR, right? Get it. So I think AVR, right arm, AVL would be, it's not leg, it would be left arm, right? And then AVF is to the, yeah, so I think foot, so AVF would be foot, right? Good. Everyone got that? All right. Which valve is heard closing during S1? The mitral valve, the aortic valve, the pulmonic valve, or the bicuspid valve? What do we think? Yes, what is the mitral valve? Also the bicuspid valve. Two names for the same thing. I can't remember if I did that intentionally or not, but I'm gonna assume I did. Let's just say I did and call it genius. No. Right. Yes. So again, when you have S1, that is going to be during what's happening there? Ventricular systole, right? So again, your squeeze of the ventricles that causes pressure to increase and close the AV valves, right? So you're going to hear the tricuspid and mitral valve closing. That's S1, and then during diastole, when you have the relaxation occur there, what's closing? Semilunar valves, pulmonic, and the aortic valve are going to be closing in that case. That's S2. That's the dub, right? Did you guys hear about the EDM musician who had an arrhythmia and died? He dropped the beat, right? I just thought of that one. I'm kind of proud of that one. Anyway, all right. Okay, outward flow of which ion is responsible for the repolarization phase of the myocardial action potential? We kind of discussed this one already. All right, yes, potassium. Okay, so remember what's going on. So let's say we're looking at the fast response cells that are responding. So looking at phase 0, what's happening? Sodium influx, right? So it causes a big depolarization. So sodium coming into the cell causes that rapid depolarization. What about phase 1? That's where the sodium channels start to close. That's where you get that little dip that occurs there, right? So again, the sodium channels close. You're starting to have a little bit of potassium leaving the cell at that point, but then you get to phase 2, which is what? That's the plateau phase, right? So you're going to see a plateau occur there. That's due to calcium influx, right? So calcium coming into the cell is going to cause, and again, why is calcium coming into the cell important? Because calcium in the cell releases more calcium from the sarcoplasmic reticulum. You have to have that calcium come in, releases calcium. That's what actually causes the squeeze, right? Actually causes the actual contraction. And then, so that's phase 2, and then phase 3 is what? That's potassium efflux. That's the repolarization that occurs. So potassium leaving the cell is going to cause the potential to go back down, right? And you may have a period where you have like a little bit of like a hyperpolarization where you get to like even a little bit more negative, but then you get back to phase 4, which is what? Yeah, basically all the channels are closed. The sodium potassium pump is working to maintain that resting membrane potential, and then it can happen again. Okay, right? All right. When do you think the relative refractory period kind of initiates? When do you think that starts? During depolarization, repolarization? It's going to be during the repolarization phase, right? Because again, there's going to be an absolute period where nothing can come along and cause an action potential. Then you have a relative period where something a strong enough signal could come along and re-depolarize the cell, I should say. And so that usually going to be during the repolarization phase. Okay. All right. Which of the following molecules serves to hold platelets at the site of vascular injury? Be serotonin, ADP, von Willebrand factor, or prostacyclin? PGI2. Anyone know what the abbreviation for serotonin is? There's the 5-HT, that is serotonin. It's 5-hydroxytryptamine is the chemical name there. So you'll see that quite frequently. Especially when you're talking about different receptor subtypes, you'll talk about that pretty frequently. I think I gave this one away already too. So, yeah. So this is actually von Willebrand factor. So remember when you have that collagen being exposed and that's kicking off the intrinsic cascade, von Willebrand factor is what's kind of binding to that platelet to start the activation process. Now, what else is activating the platelet here? ADP can activate the platelet, so you can find that will actually help to stimulate that conformation change it causes. Remember, when platelets get activated, normally they're nice, kind of a little more kind of globular shape, but when they're activated, what do they look like? The little legs that stick, these little podocytes that stick out, and that is what's going to help to bind on to other platelets there. So an ADP helps out with that. Serotonin can help out with that as well. Prostacyclin normally does what? Typically going to be a little bit more vasodilatory. You're going to find it's actually going to be inhibiting platelet activation in those cases, right? Okay, so go back and kind of review those different chemicals and kind of see what's going on as far as platelet activation goes. This becomes important when we're dealing with especially patients who have had like a blockage or they have like an MI or something, and we're needing to give them drugs to prevent their platelets from aggregating. We'll do things like give ADP receptor blockers, or we'll do things that try to modify the prostacyclin process. So we'll run into that much more frequently later on when we get to cardiovascular pharmacology. All right. A patient suffering from drug-induced agranulocytosis would be deficient in which cells? B lymphocytes, macrophages, eosinophils, or neutrophils? So agranulocytosis. It's a little bit tricky. Interesting. Okay, yeah. So this one's a little bit tricky because again, when you're thinking of your white blood cells, you think about what? Granulocytes. You think about agranulocytes, right? So you think agranulocytosis, you think you're probably deficient in the agranular cells, right? Actually, not the case. The A in this case means what? Without, right? So basically, the A means without. So you're without the granulocytes. So in this case, one of the big things you're going to find are which ones are your granulocytes? Or never eat bananas. So I'm going to do neutrophils, eosinophils, basophils, right? So those are what you're going to be deficient in. Neutrophils are the biggest thing you're going to see be very deficient. And that's why if you have this, what do you think you're at risk for? Infection is going to be a big deal, right? Yes, sir.
What would be if you're missing
A grain? I don't know. You never run into that. Yeah, I don't know. Actually, but this is definitely something you run into much more frequently. I would say. I don't know if there's a case where you have, because you can have like individual deficiencies. Say, for instance, I guess if you're deficient in your actual lymphocytes themselves. But I don't know if there's a specific term just for that particular cell line. So anyway, does that kind of make sense though? So when you run into agranulocytosis, just know that your granulocytes are what's actually going to be depleted here. Okay. All right. Which of the following patients would have increased preload? A patient who smoked crack cocaine causing hypertension, a patient who suffered dehydration after working outside, a patient who is blood doping with his own stored blood, or a patient who abused diuretics to lose weight. Or you could say the professor who was up front in the very hot classroom causing dehydration. See, increased preload. All right, so let's work through these. So the patient who smoked crack cocaine causing hypertension, what is that going to do? Increases afterload's the primary thing you're going to see increase, right? Because you're causing vasoconstriction, you're going to cause especially like the arteries, you're going to see that's going to be very constricted. Typically, is going to be the biggest increase is going to be in the afterload, right? It's the pressure your heart's pumping against. Patient who suffered dehydration would have decreased preload because again their blood volume's down, right? They're going to have decreased amount of blood actually getting back to the heart in those cases. And how about the patient who abused diuretics? Same problem, right? Because you're running into dehydration in those cases, right? And so when would someone abuse diuretics to lose weight? Bulimia could be one thing, right? Eating disorders, things like that. But I had one friend who wanted to. He had aspirations to be an MMA star, and so in order to actually cut weight and get down to a certain weight class, he actually was using furosemide. I was not particularly approving of inappropriate use of medications, but he did what he did, and he got very, very dehydrated. And I never seen anyone look so miserable when he actually did the weigh-in. And actually, like him with the other guy, he's just like, drank a ton of fluids afterwards. But yeah, so that could be one thing you can see people abusing diuretics to lose weight in those cases there. But yeah, so someone blood doping, someone who's infusing their own blood back into the system, that would definitely increase the preload, right? Because again, I have increased blood volume getting back to the heart there. Yes, sir. So you're right. So again, it gets a little bit more complicated when you're thinking about something like this situation. So, and when dealing with something like cocaine, you have purely alpha constriction, right? So you have a ton of alpha activation there, alpha 1 activation, a lot of vasoconstriction. You find that the veins are actually going to be kind of spared in those cases there. So even though you may have increased afterload, and you may be increasing that pressure there, the veins can respond, and you're going to find that there's very limited change in the actual end-diastolic volume, right? So that the preload doesn't really change appreciably. Versus something like nitroglycerin, that can actually cause like the veins to dilate somewhat, and that can actually decrease the end-diastolic as well. So again, it's a little bit more complicated, but we're really looking at kind of the main changes that are occurring here, right? Hopefully that is satisfactory of an answer, but that's the main thing we're focusing on there. All right. Patient with abnormally slow breathing would be termed hyperpnea, tachypnea, apnea, or bradypnea. Everyone should know this. Would be someone who had like normal breathing. Eupnea. Never heard that term you ever used outside of a classroom. Yes, bradypnea would be the correct answer in that case there. Good. Tachypnea would just be fast breathing. Hyperpnea, kind of increased depth of breathing, right? You have hypopnea as well, which would be kind of decreased depth of breathing, and then apnea. That's why you got to be careful when you're, especially like when I'm dealing with some of my patients who maybe have overdosed on opioids or something like that. You can look at the respiratory rate, but actually what you may find is that some people have like a normal respiratory rate, but they're actually breathing very shallow. They have that hypopnea that occurs there, and they could still be building up a lot of CO2 and potentially developing like a respiratory acidosis in those cases. So again, you always want to kind of take a look at both, like what's the actual volume of breathing and how fast are they breathing as well, right? Okay, a patient has a serum pH of 7.24, a bicarb of 20, and PCO2 of 40. We would consider this to be a metabolic acidosis. Again, bicarbs, let's say normal is like say 21 to 28. Let's say PCO2 35 to 45 would be considered normal. Again, I have character limitations on this, so I couldn't add in like what the reference ranges are, but on the test I would include that.
ranges on the test?
Yeah, I'll give you the reference range on the test. Yeah, so you'll have what the normals are. But again, I just didn't have enough characters to put all that in. Yeah. All right, so first question is, looking at the pH, so is this compensated? No, because normal is 735 to 745. Again, that will be on the test. If I put any values like that, I will give you a range here. So 7.24, that would be considered acidotic, right? So then you got to figure out, okay, is this a metabolic issue or is it a respiratory issue? Okay, so looking at this, PCO2, we said somewhere between 35 and 45, so that's considered to be what? That's normal at that point, right? So can I consider this a respiratory acidosis? No, because if it was a respiratory acidosis, it would be what? You'd have a high PCO2. It would probably be something like in the in the 50s, maybe the 60s potentially. So you know it's not a respiratory issue at this point, right? But then you look at the bicarb. The bicarb is low at this point, right? So again, down to 20. You're going to find that's low. So in this case, you say, okay, I know the patient's acidotic. It's not the PCO2 causing it, so I know it's not a respiratory acidosis. But in this case, it'd be metabolic acidosis. Perfect, right? Now, if this was compensated, what would you expect the PCO2 to be? So say we normalize out the pH, but we kept the bicarb the same, PCO2, in order to normalize that pH, would have to do what? You'd have to go down. The patient would have to start to hyperventilate to blow off that CO2 to get a compensated metabolic acidosis. Does that make sense? So to kind of work those problems, that's the sort of thing you might see potentially on any test you might have coming up maybe in the next couple of days, right? Just a suggestion. All right. Removal of the thymus would interfere with processing of which cell? Or monocytes, or neutrophils, B lymphocytes, or T lymphocytes? What do you think? All right, so again, neutrophils, not going to be processed through the thymus. The monocytes, either. Where's the B lymphocytes processed? B in the bone, right? So again, but the T lymphocytes, T in the thymus. So pretty straightforward. Good. All right. Which of the following would cause negative chronotropy? What is negative chronotropy anyway? But would it be increased sympathetic activation of the ventricles, increased parasympathetic activation of the ventricles, increased sympathetic activation of the SA node, or increased parasympathetic activation of the SA node? What do we think? When you think chrono, you think time, you think speed, right? So we're slowing down the heart. What do you think? All right, good. So let's look at what would happen in these other cases. So if I had increased sympathetic activation of the ventricles, that would do what? Increased contraction, which is another term for that is? Inotropy, yeah. So that would be positive inotropy if I had increased sympathetic activation of the ventricles, right? Increased parasympathetic activation of the ventricles doesn't happen, right? The parasympathetic nerve only is going to innervate the SA and AV node. That has no effect on contractility in an appreciable sort of form, right? So that would be incorrect. Increased sympathetic activation of the SA node would do what? Speed up the heart, right? So that would be a positive chronotrope. That would not be the correct answer. And in that case, what would the neurotransmitter be? Norepinephrine, right? So norepinephrine from the sympathetic nerve or sympathetic nervous system, activating what receptor? Beta 1, right? Beta 1 is always going to be the primary one in the heart. It's going to be increasing the chronotropy there. And then how about increased sympathetic or parasympathetic activation of the SA node? Would, obviously it's right, so it would be slowing down the heart. The negative chronotrope. What neurotransmitter is that? Acetylcholine on what kind of receptor? Muscarinic, good, okay. Make sense, everyone? Which Ig or immune globulin is primarily secreted after immunization has been achieved against a pathogen? So we're already immune. What are we starting to secrete now? What cells are secreting these? Remember those plasma cells of B lymphocytes? Yes, that would be IgG in that case. What do you secrete before you're immune to something? IgM, good. When do you secrete IgE? More like allergic reactions and things like that. So you think like an allergy, you think IgE, but after immunization has occurred, you think IgG. What about IgA when you see that? Breast milk, you think like saliva and things like that. So that's primarily you're going to see that, right? Good. All right. S1 is heard during which wave of the EKG? U wave, P wave, T wave, QRS wave. Perfect. QRS, because again, what is the QRS signifying? Ventricular depolarization. So right after that depolarization occurs, what happens? Ventricles contract. Good. So the ventricles contract, so that's known as systole. Good. So systole happens, and what closes? AV valves. Good. And that's S1. Perfect. Good. So during the depolarization, that's when you're going to have the QRS complex. That's when you're going to have S1 occur. And then when would you hear like S2? Around the T wave, right? Because that's when you're going to have the repolarization of the ventricles. That's usually when you're seeing that relaxation occurs there, right? So it's going to be more lined up with that one, okay? Because it wouldn't be the P wave is what's occurring during the P wave. You have atrial depolarization, good, but does that open or close any valves necessarily? No, because remember the AV valve's already open by that point. It's actually the ventricular diastole that relaxing that actually opens those valves up. It's not necessarily the atria that are closing, that are constricting to do that.
So atrial depolarization would occur during S2, right?
It would be afterwards. If you see it lined up, it would probably happen a little bit after. Because again, you have the ventricles relaxing. That's going to open up the AV valves. And then again, because remember, there's a period of isovolumic relaxation. After that point, then you're going to have the AV valves open up. Blood flows in passively. And then you would have, because again, the S2 is when you actually have the aortic valve is closing, right? So that closes. And then the mitral valve will open up. Blood flows in. And then you'll have the atrial squeeze. And that's when you see the P wave. So it's not really associated with any S sounds necessary, or any sounds in particular. Okay, make sense? Yeah, because again, the sounds are just going to be when the valves are closing. Good. All right. Which muscles are contracted during forceful expiration? The external intervostals, which I don't know what those are, internal intercostals, the sternocleidomastoid, or the diaphragm? Maybe like a Russian person would say intervostals. Yeah, it's perfect. All right, so what would be contracted during inspiration, just like normal breathing? The diaphragm, that's the primary mover during just normal breathing, normal quiet breathing. The diaphragm is going to be contracted. That pulls it down, and that's what's going to increase that volume there. It allows pressure to decrease. Air flows in. If I was going to have like a forceful inspiration, what's going to be contracted then? Sternocleidomastoid is going to help to pull the ribcage kind of up. How about which intercostals? The external are going to help to pull the ribcage kind of out and up, essentially. And then the diaphragm will also be engaged there as well. However, on forceful expiration, because normal expiration is done by what? It's all passive, right? Just that elasticity of the lungs and the fact that you're relaxing the diaphragm that really helps with the expiration there. But with the forceful expiration, we're going to have more of the internal intercostals are going to be contracting. What else contracts along with it? The abdominal muscles are also going to help to kind of squeeze that out, right? Good. All right. Which of the following cells express the CD8 coreceptor? It can be macrophages, memory cells, T helper cells, or T killer cells. it's actually the T killer cells. Yeah, so those express the CD8. What expresses CD4? The T helper cells, right? Remember when you have like HIV, it's affecting the CD4 cells. That's why you do a CD4 count to determine how many T helper cells they have, how constituted their immune system is, right? Because again, the T helper cells don't necessarily do a lot of direct destruction of pathogens, but it does help to stimulate the memory cells. It's going to help to stimulate plasma cells. It stimulates the CD8 cells as well, right? Okay. Up next, which of the following is an innate form of immunity? IgA from the breast milk, B lymphocytes, macrophages, or the complement system? What do we think? Innate. You guys be okay if I go a few minutes over? We're almost done, so. Because then you guys are done after this, right? Because we have a meeting at 12, so.
Okay.
Yep, so 2 correct answers here. So IgA from the breast milk would be what kind of immunity? It's more of an acquired sort of immunity. The B lymphocytes, actual to produce immunity, that's going to be an acquired form of immunity as well. However, the complement system and the macrophages, we have both of those right at birth. They're both good to go, essentially, right? So those are an innate sort of immunity in that case. Okay. All right. Again, there's no trick questions on the test. There's only one right answer, I can assure you. Tidal volume plus inspiratory reserve volume equals residual volume, vital capacity, inspiratory capacity, or total lung capacity. All right. Okay, so let's look at this. So again, tidal volume is just what? Just normal breathing, right? Just your normal kind of in and out sort of breathing there. Inspiratory reserve volume is what? What additional intake you can have during a forceful inspiration, right? So both of those together are going to be kind of everything that you can inspire. It's going to be our inspiratory capacity, right? Make sense? What's residual volume? That's what's left over in the lung after a full expiration, a very forceful expiration. That's what's left over. Again, you can't really directly measure that necessarily. What would vital capacity be? So yeah, so it'll be your total inspiratory capacity plus whatever you can have out of a full sort of expiration, right? So again, it's going to go from a full inspiration all the way to a full expiration. That's going to be your vital capacity in that case there. And then total lung capacity. You have vital capacity plus your residual volume. You can add those together and actually get the total lung capacity. Okay. All right. So again, be familiar with those different parameters and kind of what they're referring to. All right. Chronic alcoholic develops liver failure. What clotting factor might be affected here? Factor 7, 3, 4, 12. I saw a bad joke today. It says a Roman walked into a bar and held 2 fingers and says, "Give me some beer." Bartender hands him over 2 beers and says, "I ordered 5." Factor 7 is going to be one of the big ones. So 2, 7, 9, and 10 are some of the big ones. They're going to be affected there in the liver specifically. So we'll also see that's going to be a big deal when we're talking about warfarin, right? As a blood thinner, that's going to be big as affecting the liver and vitamin K utilization, all of that. So, all right. And again, which value would be most affected here? Coagulation study. PTINR would be the big one that is going to you're going to see the biggest change, right? Because that's going to be mainly looking at like the extrinsic sort of cascade there, and again, 7's going to be a big factor there. Okay. Beta 2 activation would lead to which of the following physiologic effects? So beta 2. Bronchoconstriction, hypotension, meiosis, bradycardia. What do we think? All right, yes, hypotension would be the correct answer here. Remember, beta 2 activation. Beta 2 typically does what? Relaxes smooth muscle, right? So again, you're going to see in the lungs it's going to cause bronchodilation, which is why it works for asthma, right? You have activation of those receptors there. It can cause smooth muscle relaxation of the vessels, and that can cause hypotension, right? So again, there's actually some cases where, has anyone ever heard of the substance called Clenbuterol? It's something that bodybuilders have used before in order to it stimulates beta 3 activation and actually causes lipolysis, and they use it to cut weight. But it works just like albuterol does, but it's like an oral form you can take, and you can make it in your kitchen basically. It's not that I advise doing that because again, I wouldn't trust any of us with organic chemistry and all that. But these guys would take this drug, and actually the case report, these two like big muscle bound dudes who came with like severe hypotension because they made this clenbuterol, didn't know what their dose should be, and came in and had all this beta 2 activation causing hypotension. So think beta 2 activation, think hypotension is a possibility. Bradycardia would not be correct. Typically, if anything, you might actually see a little bit of speeding up of the heart. However, that's primarily mediated through what? Beta 1, right? So which would be tachycardia in those cases there, and then would not cause meiosis. Typically, think sympathetic activation. You think what? With the eyes.
With the eyes?
Yeah. Yeah, usually mydriasis, right? So you wouldn't expect to see that either, right? Okay. Which of the following locations are red blood cells made in a 63-year-old female? Think of the femur, the tibia, the humerus, the vertebrae. What do you think? There's nothing funny about the humerus, okay? It's a good thing I don't teach anatomy. There'd be bad anatomy jokes all day long. Yeah, so it's actually the vertebrae. So remember, you end up losing a lot of those sources of red blood cell production as you get older. Typically, the vertebrae are going to be one of the big places that they're still producing. Where else? Sternum be one place. Yeah, flat bones can be useful there. Those are the primary places you're going to see with that, right? Okay. All right. Okay, we're almost done. Which of the following vessels carries primarily deoxygenated blood? The aorta, the carotid sinus, the pulmonary arteries, or the pulmonary veins? Deoxygenated blood. You guys probably had this on your anatomy test recently, right? Everyone should know this. Perfect. Well, most people knew it. Yes, pulmonary arteries. Remember, this is the one that's a little bit tricky because you think arteries, you think oxygenated blood, but with the pulmonary arteries, this is flip-flopped because we're delivering deoxygenated blood up to the lungs. Good. Okay. All right, a patient presents to the ER with massive hemorrhage. What type of blood can he receive? You don't have time to do any kind of blood testing. What can they get? We need blood stat. Mr. and Mrs. PA, what do we do? You know, one time I had a family member that died from not being able to get the transfusion they needed because we couldn't remember what the blood type was. You know, it was really sad, especially because the whole time he was just saying, "Be positive, be positive." Yes. So in this case, the safest blood that anyone can receive, if you don't have time to do blood typing and whatnot, is going to be what? O negative, right? That's why you say like O negative is universal donor, because again they don't produce any of those antigens. They don't have the D antigen. They don't have anything else, so they can give that to anyone, right? Who's the universal recipient? AB positive. Perfect. Good. Okay, let's see who our winners are. Who's Piglet? Fantastic. Good job. Kyle Herding. Good job. And Stefan. You're not sure of your own name? Interesting. Well, guess what? Your free answer for the test is D. Thank you, everyone. If you have any questions, please email me earlier rather than later.